all the important clinical trials in 6 minutes. So I have 21 slides and see how fast I can get to them. These are my disclosures. So I think one of the highlights of the stuff that came out last year was this BELIEF trial, which basically looks at the left atrial appendage isolation as an adjunct to pulmonary vein isolation compared against extensive ablation. We were part of the study. I'm very biased about it because we're part of the study. So I think it's a cool idea, supporting the concept of appendage involvement that is becoming increasingly more viable. The study really lays down the foundation for some very interesting observations. Next slide, please. So you look at empirical electrical isolation. Obviously, these are high volume centers that know how to do appendage isolation. What comes out striking is, despite appendage isolation, the recurrence rates are about 50%. And then what happens to the appendageal function down the road? I think that's an important piece that needs to be addressed. And perhaps this could be a big thing going forwards. And so the AMAZE trial would be an interesting add-on for this. And so I would like to talk a little bit about the AMAZE. It's about 170 patient enrollment through. It's a randomized controlled trial looking at appendage ligation versus, along with AFib ablation versus AFib ablation alone, along with a Cavotrax line. The expected enrollment is about 400 to 600 patients. So I think this is really going to answer some of the important questions or early observations that we have that have driven this as a concept going forwards. Next slide, please. And then comes this very interesting paper from UCSF. I think this is something that we all have been thinking about, talking about. Whenever you do a left-sided procedure, the risk of symptomatic and asymptomatic systemic thromboembolizations is huge. And that's what actually drove AFib ablation, peri-anticoagulation strategies. So a lot of us actually now use systemic anticoagulation post-VT ablation, but it has not been standardized. So this data is very compelling. It's a very small study of 12 patients. And what you see there is actually mind-boggling. So 58% of these patients actually had embolizations to the brain when they were not anticoagulated appropriately post-procedurally. So this really lays a foundation for all the VT ablations that we're doing now, probably begs systemic anticoagulation. It's a very, very small study. You can critique it how much ever you want, but I think it's a very interesting and groundbreaking concept that really need to be acknowledged. I think Stroke VT, which is a randomized controlled trial that is partially funded by Pfizer, we are heading this particular trial, looking at the same aspects of it in SCAR VT ablation, both ischemic and non-ischemic. So that would be an important trial to really answer that particular question. So again, this is the search for the holy grail, right? The pressure trial, durable pulmonary isolation. It seems to be so simple, but it still is very difficult to do. And that's exactly what they proved with this. Even in the era of contact force catheters, I mean, it's amazing to see that 62.5 patients, of which 26% of the veins actually were still not isolated. I still don't get that, right? So this is something I think still remains very enigmatic, and that really goes to tell you that when redo ablation happens, when you get really durable pulmonary isolation, your outcomes are a lot more superior. So again, going back to ground zero of how do you really improve your technique, and perhaps some of these new technologies that are coming up, I think would be very groundbreaking in that. The myth of MRI and pacemaker and defibrillators, right? So now that we have a lot of MRI compatible devices, but again, how about those devices that came before the MRI compatibility, and then you really look through all of these cases, it's very interesting to see that the overall cumulative risk is actually almost non-relevant in this whole process. So I think it's about time that all the institutions really pick up pace on this and start really using these protocols to be able to provide our patients a very valuable service. And maybe it's time for the MRI companies to start reverse some of their stances that they have upheld for a long time. Next slide, please. So that's basically, I think it's a pretty nice, large prospective study, multi-center, that really answers some of the questions that shouted. Next slide, please. And then have the cardiac pacemaker retrieval study. So this is again a small study we were involved to. Really goes to tell you that the extracting a leadless pacemaker, especially the one that has a screw, is probably not as hard as we think that it is. So we had a total of 31 patients. Most of them were successfully expanded. In fact, we have a late-breaking clinical trial on this particular topic with a new battery problem. A lot more patients have been extracted around the world. We're going to share some of that experience. Vivek is going to show that data tomorrow evening. Next slide. Next slide. So this is a little bit of an add-on to the TAVR stuff, right? So a lot of times we don't pay attention to this. I think this is an area where we should be focusing more. A lot of these TAVR patients don't really get appropriately screened for AFib, or their anticoagulation protocols are not that great. So time to really pause here and rethink about our antiplatelet anticoagulation strategies, and perhaps there is a role for really studying this in a more organized fashion. Protocols need to be changed, and is there a value to even doing an implantable loop recorders in these patients who undergo TAVRs? And we're already spending a lot of money on these people. So all those patients who don't have a pacemaker, can we make a case to really put in an ILR in this group of people? So the TAVR LAO study, which is I think going to be led by Samir Kapadia from Cleveland Clinic, is going to really touch this aspect of that. And then there's a lot of observation data that has already come from Europe on the amyloid device that I think is pretty compelling to show that appendage closure may be a very reasonable add-on procedure for these patients. This is again nice work by Dr. Calkins and group. Again, the results of this particular study are quite contrary to our earlier observation study that we presented back in 2011 that showed that dabigatran had a higher risk of complications, delayed procedural complications of tamponades and delayed hemorrhages. But I think this really opens up, put that question to an end. This is exactly what we really needed. I think it really clears the dabigatran's so-called shorter effect in a bigger way. Next slide, please. Next slide. The defibrillation implantation in the non-ischemic cardiomyopathy. I think this is an area of big controversy, and I'm sure some of the earlier speakers might have already shed some light on this. What this really highlights is, unlike the previous impressions or the previous data that really that we went by, do we really need to relook at this entire spectrum of non-ischemic cardiomyopathies one more time, rather than bundle them up into one big group? Maybe it's time for us to really delineate and substratify these groups of patients and really identify the rightful patients that are going to get the best benefit from that. So I think that would be the next phase of the evolution of our risk stratification processes for non-ischemic cardiomyopathies. Next slide, please. All right, I think my time is up. Thank you very much.